Statewide Biobank is located on the lands of the Gadigal people of the Eora Nation, and I'd like to pay our respects to Aboriginal leaders, elders past, present and emerging, and thank them for their many contributions to not only science and ways of knowing, but all aspects of life in Australia and New South Wales. So I'm just going to ask people to pop themselves on mute if you could. I'll introduce our speaker. We're very pleased to have Dr. Wayne Dyer, who I think the Biobank has known for a number of years. So Wayne is he's a biomedical researcher, and he obtained his PhD in HIV immunovirology, and he has extensive research experience in the blood sector. So his current research interests include clinical and applied patient blood management, optional use of fractionated plasma products for haemorrhage and coagulopathy, and also the evidence-based use and demand modelling for immunoglobulin, immunotherapy, and research biobanking. So Wayne will be talking to us today about his biobanking interests, and specifically he'll talk about the outcomes of Lifeblood's feasibility study for a blood donor biobank and health data linkage study, which has been established using fairly minimal funds to support blood donor health and behavioural research, blood product safety, and Australian population health and research outcomes. And so he'll talk about some of what's been learnt about the feasibility study, and I'm sure that this is a topic that's of interest to many of us, particularly I would say the statewide biobank, because one of the most frequently asked questions that we get from people is how can we access control samples? So this is a big issue in research. The availability of appropriate, well-matched controls for studies is really critical. And I think when I heard Wayne's presentation at the ABNA conference last year, I thought that this would be a very interesting topic for the people that attend our seminars as well. So Wayne, thanks so much for being available to talk to us. We look forward to your presentation and to having some discussion afterwards. Thank you.
Great, thank you. I'll start launching this. Let me know when you see the page. Is everyone seeing that?
Not yet, Wayne.
Great, yet. That's good. Not yet.
Not yet, not yet. No, it was good before. We could see it before.
Let's try again. Push the button, push that.
Beautiful.
Now it's good, Wayne.
Fantastic. Okay, great. Well, thanks for joining the seminar, everyone. Today, I wish to share our experience in establishing a new biobank, and some people go through and think, well, why did I not do it this way? But first of all, just to reiterate, it was a feasibility study conducted in the research setting, but we were using standard operational processes at Lifeblood because we wanted to use the learnings from a feasibility study to plan how to translate this to an operational business as usual function in Lifeblood throughout the entire system, and with the aim, of course, of representing the whole Australian population. So just by way of introduction, I just want to talk about, well, when you think about establishing a biobank, you really want to have, good utility of the biobank to maximize its value. And well, when I'm talking about value, I'm not referring to the costs of establishing and maintaining the biobank versus the usual minimal amount you may get back from cost recovery when releasing samples. But what is the inherent value of a biobank, particularly long-term relevance of a well-designed biobank? Well, in the context of specialist biobanks, the maximum value can be obtained if the consent for use of the biobank is broad, in fact, beyond the original application of a specialist discipline. For example, a cancer biobank, you may want to be able to support future research and diagnostics from these samples. In terms of a blood donor biobank, well, we're considering how could this support research beyond transfusion medicine? And we're thinking of population health outcomes, emerging infectious disease screening, and even perhaps contributing to serosurveys in time of real need. So the value of biobanks is also dependent on how comprehensive your metadata is. Now, it is a fact. Samples with poor or missing clinical and demographic data rarely get used. They stay in the biobank. So So for specialist biobanks, collecting data is essential. Again, broader than the initial scope, because it'll really help maximize future relevance of any research that may not have even been dreamt upon when initiating this biobank. And again, this raises the issue of intuitive ethics committee support. And again, there are some situations where the collection of data should be tailored specifically and only to what's needed for a study. But when it comes to biobanks, where samples are collected for long-term use for studies that haven't even been thought of, it really shows that there is a need for maximizing the scope and breadth of data collection in order to make this expensive resource useful long into the future. And another value really is high quality sample processing, storage, really to maximize the long-term viability and functionality of legacy biobanks. And for example, when it comes to using a biobank to look for understanding, say, COVID, if you want to look at samples pre-COVID, your biobank needs to be, before 2019. If you're looking at cross-reactivity with other coronaviruses, you might want to be getting samples pre-MERS in 2012 or even pre-SARS in 2003. So it really shows the need for good quality handling of samples, and starting off with a very well handled, say, for example, peripheral blood mononuclear cells, really good technique. When it comes to immunology, understanding, say, for example, what are the baseline immune responses or viral genomics, even drug metabolomics, for example, in the HIV research field. What happens perhaps before the introduction, say, a new class of drugs? When you go back to when highly active antiretroviral therapy was first introduced in 1995, to understand what individuals were coping with prior to effective therapy, you really need 30-year-old biobank samples to actually do this research. And at this point, I'll just give everyone an unapologetic plug for some work we've just performed and published last year, a paper about preservation of functionality, immunophenotype, and recovery of HIV RNA from PBMCs going back 27 years. So we were able to show and demonstrate the value of a legacy biobank if the samples were carefully planned, you had the right metadata, and you looked after these samples. And it was very remarkable what we could actually do. This study also was great comfort to people with legacy biobanks, wondering, were their samples still useful and fit for purpose? So when considering a new biobank for blood donors, it's important to really understand your target population. And when it comes to population and collection bias, recruitment is very important. Well, how is the target population notified? What are your demographics most likely to consent? Now, in our situation, it's blood and plasma donors. And we had obviously very experienced donors, but we also wanted to know whether some new donors would consent. What are the logistics and sample processing considerations? Where to collect samples from our different donor centre networks around Australia and have the samples sent to the regional state processing centres. We needed our serum sample spun at that location, and then before on shipping to Sydney to where our biobank was. And that involved, timely logistics, having chilled shippers, and also understanding what were the likely uses of our samples in regards to whether specimens needed to be spun quickly or frozen quickly. Inventory was another consideration. There's just some different choices, from simple spreadsheets to databases to LIMS. Do you use alphanumerical labels or 2D barcoded tubes and racks? And that's the consideration, is whether how we could transfer this to other end users too, and whether or not the biobank could be completely transferable. So again, this was a pilot study. We did have a limited R&D budget to do this in the research environment as a proof of concept before seeking full funding if it was applicable to translate this to a business as usual operation. And for ethics, we tried to keep the data collection as broad as possible too. The other consideration is sample stewardship. So what is the utilization plan for your biobank? Were the pre-planned studies appropriate? Do we promote this to other internal R&D research? And very importantly, how do we promote this externally for external use? So we considered different societies like ABNA as to be very important for helping us to sort of get the data out. And appropriate resourcing for long-term use of a biobank. Again, this always links back to stewardship, because how do we plan to keep the work going? Will the samples be used? And fortunately, what we are doing, at this stage, we have got good indications that Lifeblood is interested in a business as usual biobank as well. So the rationale for blood donor biobanking, what's important to note that is research in blood donor health could actually address a lot of issues associated with blood donation, blood product quality, potential impacts on transfusion safety, and also provide a deep insight into the long-term health and well-being of our donors. So to this end, other blood services around the world have developed blood donor biobanks. What's interesting here with the ABDS study, we've not only have collected our samples and questionnaires. What's unique so far about this study is being able to link with external health data linkages. So that again expands the metadata that makes our samples quite valuable. So we completed an initial phase in 2024. In 2026, we plan to expand our numbers to 10,000 before handing this over to the Lifeblood as a business operation. So an overview of the actual study. In order to collect biological samples relevant to the Australian population, our aim was to do this as a feasibility study. We aimed for 6,200 samples from whole blood and apheresis donors with all the data sources linked as possible, but processing using existing Lifeblood infrastructure. The objectives, of course, were to demonstrate the utility of this collection that we would generate in a number of different donation, blood donor and transfusion safety research projects. The measures that we were interested in were how representative of the Australian demographic and the population, and how timely we could ship these samples to Sydney and process these. I'm happy to note that the outcomes were quite successful. We achieved our recruitment aim after 15 months. The follow-up surveys are ongoing, and we're still waiting to link in the external data linkages. We have the permissions progressing to do this. We were already conducting internal research projects in both genomic, behavioural and population studies. And interestingly, this is a research asset that will be available soon. We've already had 3 external sample requests. So we hope to, again, be able to be in the position very soon to start releasing samples. And very importantly, we are in the process of planning translation to Lifeblood as a business activity. The methods and design considerations are something that everyone who starts a biobank will be interested in. Again, the feasibility study is an important limitation for what we did. But again, with a small budget, we were able to achieve this. When it comes to recruitment, pre-donation electronic invites were sent out, and then upon consent, online surveys captured data into a REDCap system, and then we use standard donor communication tools to reach out to our donors before collection. With blood donation centres, we had to use manual donor management tools prior to flag the request for samples when donors visited different donor centres. And then we had to manually remove the flags after the collection. And this is important to prevent repeat collections, because these weren't approved by ethics for this particular study. And unfortunately, any repeat collections made in error had to be discarded. The daily sample forecasts, though, were provided to the biobank, and these were extracted from Lifeblood's blood management system and sent to us as a guide for possible samples that would arrive in Sydney. This was a staged recruitment around Australia. So another important note too was the choice of the different donor centres in each state, starting from Victoria and Western Australia and finally rotating around Australia and to New South Wales. The choice of the individual donor centres that would participate were actually made by Lifeblood's donor services team. The consideration here was that other research studies conducted at a donor centre meant that that donor centre wasn't available to us. And if there was an important implementation program progressing, we couldn't have access to the donor centre too. So in a way, that was introduced a small bias to what populations we were able to collect from. Again, the budget was modest, so the materials that we used were pretty well laboratory grade materials. We did not use 2D barcoded tubes. They were too expensive for us. We didn't have a LIMS to manage our inventory, nor a robotic inventory management freezer system that some of the professional biobankers have. Sample size was powered for one of our genomic studies, and this was to look at a condition called pseudohyperkalemia, and that in simple terms means excessive potassium leakage from red cells during storage. And this is an important study to know. We don't really understand the breadth of this situation, but it is important to try and identify this because excess potassium in red cells is dangerous to neonates and cardiac patients. So again, this is an example of applied biobanking and research from this. So how do we go? Now, the time frame for recruitment, after a 1-month pilot in November 2022, we commenced recruitment in May 2023 until August 2024. And this was staged across 4 major waves of recruitment, starting in selected donor centres in Western Australia and Victoria, then Victoria, South Australia and Tasmania. Then we moved across to Queensland with a few mobile centres in Tasmania, in South Australia, and finally in New South Wales. And we'd had a 6 to 8 week break at the end of each year to give the donor centres a bit of a break as well. We recruited anyone who had donated previously, either whole blood or plasma or platelet donations. These were invited to participate from an email invitation 2 weeks before their scheduled planned donation at the donor centres during the collection window. And what's interesting to note, we used different Lifeblood communication tools that are routinely used to increase the level of recruitment engagement. So after the initial invite, we had about 12% response. Reminders were sent with a boosted response at 18%, and at Lifeblood's regular SMS system was used to get up to 24%, which was fairly consistent throughout the entire collection period. So in terms of donor and consent, we had about 9,000 consent to this study, and nearly all of those provided their pre-donation demographic survey. Now, of these, 71% were able to donate within the window period of collection at each rollout in different states. The health and lifestyle surveys were completed 2 weeks after donation, and the annual follow-up surveys are still ongoing. And what we do note from this study was that consent was very high, indicating good engagement to link to external data sources. Most donors were really keen to hear their test results and learn about research funding. So that really shows that the study, as well as providing data and a biobanking collection, was great for donor engagement as well. Our donor demographics, as the data show, as the figure shows here, shows donors spread throughout the Australian population. Now, this shows the postcode of the residential postcode of where the donors lived at the time of donation. Numbers were reasonably divided between sex, and although this was a pilot study, the level of engagement, again, was quite good. But note, we had a slight demographic bias. In this study, we are comparing ourselves to the Australian Bureau of Statistics National Health Survey. And the data from 2021 shows that the median age of Australians was 38 years. Because we had a recruitment based on that tended to be to people with more experienced and more prior donations than those who are relatively new, who did not consent, our average age was actually 52 years old. So it is a little bit different to the average Australian population. So this just goes to show that consent, methods of consent can actually add a small bias if you're looking to comparison to a normal population. Also, the numbers collected by state did not compare to the Australian population. The reason for this was our planned recruitment waves. In order to simplify processes at Lifeblood, we started with Victoria and WA. By the time we finally got the recruitment wave came to New South Wales, we were getting close towards our recruitment target. So that's the reason why New South Wales was a little bit underrepresented compared to the distribution by state in the Australian population. And we also note too, with this initial phase of collections, we did not collect from the Northern Territory or the ACT. One thing that weighs on people's mind is the ancestry characteristics of our donors representative of the Australian population. Or short, there was a skew towards a more European population. And compared to the Australian population from the Australian Bureau of Statistics, only 25% were born outside of Australia in our study, whereas up to 31% were born outside of Australia, based in 2024 data. And as you can see here, there is a need for future collections for the Australian Blood Donor Study to maximise collections from a broader representation of the different major ancestry groups. But one thing we can note is that because this was a pilot study and we were not collecting from all donor centres, we were biased a bit by the availability of different donor centres, including some donor centres in Western Sydney that weren't available to us, which would have increased our diversity of ancestries more than what we had. So another big question to say, are the health and lifestyle measures of the ABDS donor cohort comparable to the Australian population in general? We compared data from the National Health Survey conducted by the Australian Bureau of Statistics, and this is by and large the 2022 data, which is reasonably comparable. Important to note, these are direct comparisons. This is looking at a threshold, the percentage of the individuals that are within a particular band. For example, in body mass index, whether you're obese, overweight, or normal or underweight. The data is not in any way a distribution analysis. We do not use any complex statistical analysis. It's simply reporting the percentages in a particular data threshold. But what we can see from this data, when comparing the Australian Blood Donor Study, when you look at smoking, a lot less smoke compared to the Australian population. Blood pressure, slightly less in the over blood pressure category, and a little bit less in the top category of alcohol use. So slight evidence of a little bit more healthier cohort in the blood donors. Also, what's noticeable here, iron supplementation. Our blood donors are very well aware of the need to supplement iron, and we see in terms of female donors, blood donors take more iron supplements than the general population. By and large, though, daily fruit and vegetable consumption was fairly similar. General health reported by the participant, slightly higher in the blood donors, as we would expect. What's interesting too, though, is the level of physical activity was slightly less in our blood donors. And if you understand the age difference in our donors compared to the general population in this particular phase of our study, it's probably not too surprising we see some of these differences. Again, when we move into a broader collection, we also will be getting the raw data from the National Health Survey and conduct more meaningful statistical analyses comparing the donors with the Australian population. So what was the outcome in terms of how we want to learn from our initial collection phase in terms of changes into different strategies for recruitment, and how could we translate these? Well, the future recruitment will definitely be based on collections from all of our donor centres to maximise full population representation. However, what we did learn from this study was what we do need to particularly target our different migrant populations to increase the ethnic diversity. And one thing we will do is to provide multilingual participant information in consent forms, FAQs, and have these on their website as well. Importantly, it's also important to target a younger donor population by reaching out to people who are new donors without a long donation history, because the people who did consent were by and large very experienced donors. So how does this translate to future research? Well, what we really aim to do here is, as the slide shows, grow an engaged and health-aware culture in our own donors, in our own donor pool, and to also support general health awareness in the Australian population as well. And by getting data and showing this, we'll be able to show that there may be further evidence for the well-reported healthy donor effect. And to do this, we must have more younger donors, just to really show that this effect is across the entire donor pool. Getting to the biobank side of things, here's a simple process pathway. We received from our donors an EDTA plasma tube. If there was enough blood available, we'd also received an SST serum tube. And these were spun in the local capital city processing centre before sending to us in Sydney. And we extract the next day upon arrival and store in -80 freezers. DNA then is brought out. Buffy coats are brought out in batches, and DNA is extracted, and we're currently going through the DNA extraction phase at this stage. For future collections, we're considering also keeping some of the packed red cells at the bottom of the EDTA tube. Just one particular study that I was thinking of was, if we were to use the red cell concentrate to study hemoglobin A1C, we can understand diabetes and metabolic health in our donors too. So red cells can be quite useful for this. So what were our quality measures? Well, we did get fewer serum than plasma. This is our current inventory. We've got over 6,400 samples. The reason why we had less was because in whole blood donation, a diversion pouch is used to siphon off the first 50 mils. It sort of lets any impurities from the venipuncture flow into this before collecting the purest blood into the donation pouch. All the mandatory blood testing is taken from this diversion pouch, and any other testing, and we get our biobank samples from this as well. So when there are many samples needed for other tests, we're only able to get one blood tube. And this is a consideration, and we are planning to be able to get both plasma and serum moving forward. The quality measures, virtually all serum tubes were spun within 24 hours, and that's important for some of the tests that are conducted in Lifeblood. Very importantly, when you look at the number of different path lab specifications, some say less than 2 hours. When you go delving deeply into the manufacturers of the commercial tests, so long as the serum is spun within 24 hours and it's not hemolyzed and it's clean, it's actually quite fit for purpose. So this gets done routinely in our different processing centres. So by the time they are received in the biobank, possibly 2 or 3 days later, these are well spun. As you can see by the distribution graph of time to process, this represents really the effect of shipping blood either from the local New South Wales donor centres to the biobank in Sydney. There's a cluster at 24 hours time to process. When further out to Queensland, Victoria, Western Australia, it's typically 48 hours. And in some of the remote areas, or when collected on the weekend, it can be 3 days or longer. What's important, though, when we look at the quality measures, the level of hemolysis, or breaking down of the red cells, was quite low in our serum and plasma. Very few samples were lipemic. You could tell the samples that were collected after lunch by a slightly higher lipemic fat level in the plasma. And very importantly, we've conducted a series of data reconciliations, both with the data collected into REDCap and with when these were confirmed also when manually releasing our first complete set of samples from the biobank to ensure that all the data collected and the numbers in our inventory reflected what were actually inside the freezer. So a question that everyone may be asking, without the budget for fancy LIMS and wonderful 2D barcoded tubes, how do we cope with Excel? Well, a simple way that we did this, I'll give you an idea. We used Excel to capture all the data during processing. Now, we scanned the DIN label on the blood tubes. Now, the DIN label is the donation identification number, and that is what we use to link back to the REDCap data bank. From there on, though, it's all manual entry. The collection time and date punched into a spreadsheet, how many samples received, the level after spinning, was there evidence of hemolysis or lipemia, what were the other sample quality notes that we entered manually, how many aliquots were stored, where they were stored, the time to process. When we took the samples to the freezer, we put our initials in, which created a timestamp, and we had a time zone and saving time offset calculation too. So we can actually calculate the exact time it took to process and freeze our samples from blood collection. And the complete weekly tally of samples and the data was uploaded into REDCap as well. How we managed to do this with Excel when it came to the inventory was using a base 10 inventory arrangement. As you can see from our samples stored, it showed that one single donor was placed into a row with 4 serum, 4 EDTA plasma, and 2 Buffycoat samples. And this made it easy to locate our samples. And then we had consecutive boxes with samples number 1 to 10, 11 to 20, etc. And each rack of 25 boxes were 1 to 250, 251 to 500. So it was relatively easy when looking at our Excel-based inventory to know where to get our samples. And because the different sample type were in specific columns, it also made it easy to sort the data based on columns, based on any other characteristic, even based on whether or not a serum sample was free of hemolysis. So we were able to sort and get our samples for release to investigators and to find them all simply based on Excel. And that's quite a feat, really. But I know that many with a larger biobank will shudder at the thought of using Excel. So this looks like it's a blank slide. I don't know why it's blank. We'll move on. Okay. So what was the outcome for, first of all, Lifeblood's operations? This figure shows how ABDS fitted in with a lot of important objectives to do with donor health, product quality, donor behavior and engagement with donors, maintaining supply, and also supporting population health. This was our plan. And by the end of the study, this feasibility study showed that we could actually support these objectives. We're already conducting a genomic study of iron metabolism in our donors for donor health, and also the genomic study for red cell storage characteristics. We're also looking at a number of different behavioural studies with donors, trying to understand donor retention, engagement, and seeking feedback from donors. And feedback has already shown that donors are really keen to be involved in research, and particularly this research study as well. And moving forward, we're going to promote health awareness with our donors by linking in with the general Australian health data with a proposed dashboard of donor health and population health. The other outcome is we have a wonderful research asset available now for external collaborative research, which some of these potential research partnerships we are interested in looking at donor health versus recipient outcomes. Again, the Australian population health is an important aspect, and there's a lot of scope for infectious disease epidemiology and control populations. So that's another situation where people are interested in access to control patients. How are we going to promote our collaboration? Well, we are an ABNA member biobank, and I'm actively involved in the clinical trials and cohort study special interest group in ABNA, where we are aiming to maximize collaboration with other biobanks to maximize our ability to be visible to different end users. So if anyone wishes to collaborate, abds@redcrossblood.org.au for more details. So in summary, what have we learned from the pilot? Well, when it comes to the learnings and our future strategies, yes, it is feasible to conduct a biobanking study using the existing Lifeblood logistical donor services and manufacturing procedures. However, we did learn that we do have to have a study-specific DIN label, and this will allow the different robotic systems of handling blood tubes to specifically identify our blood tube. It'll automatically help with updating records, and in addition to just using the standard shipments between the different Lifeblood processing centres, we may have to pay for some additional shipments if there are certain times where there's not enough, and we've already identified this. Demographics, well, yes, an older European-centric ancestry. We are going to change this by not only promoting or using all of our donor centres, but to make it comparable to data from the National Health Survey. We definitely need to have a broader demographic base within the population. Future collection strategies, again, all centres, migrant populations will be definitely targeted by doing this, and to get a younger population. And the biobank, well, Excel, yes, it was okay, but larger numbers. We do want to be able to auto-populate in our spreadsheets, our processing spreadsheets, instead of having to manually enter. So we're looking at ways of using our blood management system to obtain this data upon scanning the DIN label. We will be planning to use 2D barcoded tubes and racks and scanners and picking devices. This is the only way to really effectively handle very, very large biobanks. We need a LIMS for effectively finding our samples in this arrangement too. What this also will enable us to do is to not only make it easier to find samples, but to have space consolidation. For example, when we had to discard a set of samples from a donor, we just left a blank row in our box. This kept the base 10 scheme to make it easy to find our samples, but in order to be more cost effective, we want to make use of all these spaces as well. So you do need to have a LIMS system for this. And the real question is, do we go in now and convert our single freezer into a freezer farm in a temperature controlled room, or perhaps go down the pathway of using the robotic freezer systems that some very large professional biobank systems use? But I wouldn't be surprised if most of you out there are still using freezer farms as a reasonably effective way of going about this. We are thinking, though, of also the long-term ergonomics, though. So again, it really depends on, you do need megabucks for these robotic freezer conditions. So I hope everyone has considered a number of different aspects in your biobank that you may have learned from ours. We learned a lot about doing this feasibility study. We're definitely applying it to a larger study in the future where it will become a collection across our entire donor centre system, and something that's going to be of great use to not only our donors, but also to the Australian the Australian population as well. So I'd like to acknowledge my team in the biobank and thank all of the ABDS investigators, the additional clinical data management team, the many donor centre staff that have helped, the logistics staff, and those in the manufacturing teams who in a timely manner spun and sent our samples onto us. Most importantly, I do want to thank our blood donors who are continuing to supporting the research that we are performing. And thank you all for listening.
Thank you, Wayne. That was fantastic. Thanks very much. I can already see we've got one question in the chat, so I might start there. But yeah, if people have got questions, yeah, please pop up your hand. I can see somebody else popping up their hand and I'll call on you. Or if you're not able to ask questions where you are at the moment, yeah, feel free to use the chat. But I'll start with a question from Laszlo Irini here at the Statewide Biobank. He's asking about which Excel functions, extensions or add-ins were you using?
We used a lot of VLOOKUP and ZLOOKUP, and a lot of search functions. I could probably share more of the technical aspect if you wish to contact us.
Thank you. I'm just seeing somebody's got their hand up. Oh, Kate.
Kate.
Hi, thanks, Wayne. That was really great and good to see that amazing network being leveraged there. I just had a thought while you were talking about serum and EDTA plasma and buffer coat storage. Could you potentially look at expanding for a subset of donors, maybe getting, I know a lot of the buffer coat components from blood donations get discarded. Could you potentially get a subset where you wanted to have matching PBMCs and maybe nab the buffer coat before it's discarded? I know we order them as research buffer coats, that's why I'm thinking of that. And create a small PBMC subset as well. I understand that, you can't do those numbers for PBMCs, but have you thought about setting that up as well?
We've definitely thought about that. I mean, PBMCs are gold. The amount of work you can do with PBMCs, immunological studies, subset analysis is essential. For the pilot stage, this really just wasn't feasible in terms of numbers. In terms of the kind of projects we initially wished to perform, a lot of it was genomic and biochemical based. So PBMCs, again, weren't the highest priority. We haven't totally discarded PBMCs in the future. The idea of using buffies is one option. I even thought about the possibility of keeping half the buffer coat for or do one of John Zaunder's rapid spin methods in an Eppendorf tube, and actually just using the neutrophil layer for DNA extraction. These again do require a lot more staff, a lot more time, but there's no doubt there's a lot more value in that as well. Beth, you have a question too, or Kate still?
Hi, Wayne. Thanks for a great talk. Just thought, I'm from the Statewide Biobank. I think I connected with your team about a year ago during the pilot study. But yeah, if you guys want to reconnect to talk about scalability, definitely happy to chat more. But my question is, in my past life, I've used some of the fresh blood material from Lifeblood. I was wondering if the metadata that is now being accessible with the frozen specimens, is that something that can be tapped in the fresh blood space?
I have to sort of look at that as a sample request. If you were to place a sample request to Lifeblood, again, not all of the data that we are collecting and that was approved and consented is really available for external use, but anything collected into the biobank will be available for sharing. One thing I'd like to also just to remind people too is that the Australian Bureau of Statistics, through their National Health Survey, also commissioned a biobank during this last data collection round, and that was collected, and they have a fairly large set of samples, blood samples, urine samples from the National Health Survey. To my knowledge, that still isn't available for use yet, but it will be. The CSIRO folks who manage this, and then actually the data, all the samples are stored at the University of Newcastle Biobank. These will also soon be available for collaborative research as well. So we are comparing our donor data with this cohort, and I think combined, the samples from both cohorts will be very interesting for population research. Wayne, you have a question?
Oh, hi, Wayne. Also Wayne from the Victorian Cancer Biobank. It's good to see you again, I guess. Thanks for promoting the SEEK, or the specialist interest groups of the ABNA that we sort of interacted. It's very good to hear that Lifeblood has this biobanking initiative, and I think on a similar note from our biobanks, we do have some interest of how exploring how do we, similar to what Jennifer mentioned at the beginning, is how do we actually make the controls for our researchers that we're supporting as well? So we may want to have that conversation at some point. But the questions I guess I have is on the note of your consent and the person data. Is that is stored in the Red Cap? Are they stored just at the New South Wales, or is that sort of because you have a nationwide collections?
Nationwide collections. The Red Cap is available across all of our systems. While you're on that, can I introduce everyone to Dr. Surendra Karki, who's the principal investigator of ABDS, and maybe if anyone has any, or just Surendra, do you have any other comments you may want to make about ABDS as a universal source of samples for this level of research?
Thanks, Andrew. Thanks, Wayne. It was a great presentation. So you have covered everything. Just in the last acknowledgement section, I guess we probably missed to include our university collaborators who provided a lot of support in the initial stage of the setup of this study. These include Professor Betty Liu and from UNSW and Ian Shears, and Professor Katie Bell from University of Sydney, Professor Andrew Hain from UTS, and our international collaborator, Dr. Katja van den Werk from the Blood Service in the Netherlands. Yeah, and I guess it was a great team effort within Lifeblood, and it involved many different groups from manufacturing, testing, donor center staffs, and a lot of other groups involved. So I would like to thank everyone who sort of helped in I guess one way or other way in this journey. So thank you very much for their contribution. So otherwise everything is covered. Wayne, thank you very much.
Yeah, thanks. No, it just really goes to show people what it really takes to set up a biobank. When we started collecting samples from HIV patients in the early to mid 1990s, we were just recording things in notebooks, and we thought we were quite high tech, making Excel spreadsheets. But to be able to again, what we found was that it was a lot of effort to go and retrospectively get clinical data, but only those samples that we got clinical data for ended up getting used. Even as just random controls, people tend to want to have some kind of clinical data. So converting just a bit of research into a biobank isn't always successful. It really is important to initiate your biobank, plan your biobank, understanding all that it takes to make it useful for future work, the longevity of the biobank, and make sure all the systems, the quality systems, are in place before spending money, and also before engaging participants, because it's not ethical to really collect samples that aren't really fit for purpose.
Yeah, I think that's a great summary of biobanking in general, Wayne. It's something that is often underestimated until people start to get involved in it. And as you say, if you really want to do quality biobanking, that's that takes substantial effort and buy-in from many teams. And so congratulations to yourself and the team on what you've achieved. I think we all recognise that it's been a considerable amount of work from a lot of people. I wanted to just, while you were talking about like increasing the awareness of the biobank and the collection, and I'm going to pop into the chat the details about the New South Wales Biobank Certification Program, which has a biobank registry or a biobank locator. And given the fact that the Statewide Biobank does get regular requests for control samples, you might want to think about just registering for biobank certification, and then that can allow you to actually add the biobank to the biobank locator, which means that people can find it and then contact you directly. Obviously, we'd be sending people towards yourself, but it's easy. It's even easier if you're actually on that locator. So I think we've got 66 registered biobanks across New South Wales, and it's the biggest biobank registry across the country that I'm aware of, although I am aware of some others that have started more recently in other states. And I also popped into the chat some congratulations to both Cassandra Griffin and Wayne Ng, who are here with us today. They were amongst the international recipients of the ISBA Special Service Awards, and that's great testimony to their many contributions to biobanking in Australia and internationally. So congratulations, Wayne and Cass. It's great to have you here and great to see your work recognised. Hope you don't mind me popping that in. I just thought.
That's a surprise, but thanks, Jenny.
And sitting here blushing.
Oh, that's very good. I'm very pleased. I'm very pleased.
Thanks,
blushing
Jenny.
On and off camera. That's very nice.
Too red to go on camera.
Oh, there you go. That's all right. I'm probably going red for you. Does anyone else have any other questions? I guess, Wayne, I wanted to sort of ask, you had really high rates of data linkage. I might have missed exactly how the data linkage worked. Were you linking into data that you already had within Lifeblood, or were you linking out to other forms of data?
This is out to other forms of data. And Extran, do you mind if you comment on this as well?
Thanks, Jennifer, for the question. So I think probably just to make it clear, so the percentage that Wayne showed in the slides, the 90, upper 90 sort of percentage, this is their consent to link the data for external data sets for research purpose. So we in the participant information said we had provided them information about broader future research, and there would be opportunities for research where their data may need to be linked to data sources such as the hospitalization data or the data that comes from the MBS or PBS. And in that context, they were in the consent, they were given an optional consent if they want their data to be linked for the research purpose. Then in that context, they say that 97 or more percentage of them say that they are happy for us to link their data. So we haven't done any external linkage yet, but this is more about the consent for the external linkage.
Right. Yeah, that makes sense. Yeah, no, that certainly data linkage is not that's a substantial, body of work in and of itself as well. And I guess another question is whether or not you've had any discussions with the SDPR team in terms of data linkage, around the single digital patient record system that's being established in New South Wales.
No, not yet. Initially, when we sort of thought of data linkage to include in this sort of a biobank study was that we sort of contacted with the AISW at that point of time. Also, because our donors come from different states, so there's there are different data sometimes also held by the state level. So there is a bit of a complexity on that. So initially we discussed this with the AISW ethics committee about what are the requirements around sort of using appropriate wording, so the information that needs to be given to the participant for us. And in the later stage, of course, we would need another maybe mostly project specific linkage approval. but we sort of initially at least discussed with the ASW ethics committee to sort of have that information in there, so that the likelihood of projects in the future being approved for data linkage are actually approved. But
Yeah,
no, the NSW, the single patient sort of data linkage, no, we haven't discussed anything on that.
No, that's fine. I just thought I'd ask. Well, look, thank you both for coming along. Thank you, Wayne, for a great talk. Thanks, Surrender, for also being here to help with the discussion. And I'm sure that, everybody here's really enjoyed the talk, but I'm sure many other people are going to listen to it when it's online on YouTube. So thank you so much for your time. Thanks, everybody, for attending today and for your questions. And our next seminar is, I think, on the 30th of April. And we'll have Professor Daniel MacArthur talking about the 1DNA study. Thanks, everybody.
Thanks for coming.
Thanks, Wayne.
Thank you, everyone.
Bye. Bye.
Bye.